of information. I am a technology transfer specialist with the Opioid Response Network, and was, asked by the ATTC and trained by the ATTC in contingency management. I've been with ORN for, I think, 10 months now, so still fairly new. My colleague Marvis is also on the call. She's been with the Opioid Response Network since its inception and has been a great mentor for me, and usually has answers when I don't, mostly always has answers when I don't. So it's great to have her at my side when I need her. But just, I don't have a slide deck today. I'm not a big fan of slide decks, so I didn't prepare one. I hope you guys don't mind just kind of having an open discussion about contingency management. If you have any questions while I'm speaking, you can certainly ask them, or if you wanted to wait till after the kind of short presentation that I have is done, you can do that as well. So I'm just going to jump right into it. Basically, what we're talking about is contingency management. Kind of what you'll see is I'm a huge advocate for adding contingency management to any recovery program. I think it's a great resource, a great tool. Anytime you provide additional opportunities for people to connect with recovery, it just increases their chance of success. And I think that contingency management is a great tool to have in your toolbox. A lot of times, individuals who are struggling with addiction have additional issues that they're struggling with, whether it's employment, financial problems, or even relationships. It can be beneficial in programs to offer incentives to these individuals during this treatment time, because it builds this idea in their mind that doing good means that good outcomes can happen. So that's kind of where contingency management is. Whether we know it or not, obviously we've all been kind of a victim of contingency management. Basically, if you have kids and you provide them with an allowance for doing chores, you're providing them an incentive for doing something good, right? We use it with our pets, our friends, even in our employment. Employers will give bonuses for people who do outstanding work, right? So it incentivizes you to do some, to be better and to do better. One of the reasons is because it's a positive recognition, right? It's a form of therapy that aims to promote healthy behaviors around abstinence and recovery. We use rewards or motivational incentives. They can include anything from prizes, cash vouchers, movie passes, gift certificates, even just positive affirmations are things that you can offer in these programs when you're putting them together. They can really be designed any way that your program wants to implement them and use them. Again, it's a form of therapy that offers patients an additional incentive as part of their rehab. A lot of times we see individuals who are in recovery are there because they're court ordered to be there, or they might have been part of an intervention and their family has given them an ultimatum to be there. So they associate recovery with something bad, right? So we want to change their perspective of that and let them know that recovery is a good thing, and we incentivize them for being a part of their own recovery journey, on top of obviously being in recovery and staying sober from whatever their substance of choice is. These are additional incentives for just participating in their own personal program and journey. Obviously, we know people who struggle with substance use, alcohol, opioid stimulants, nicotine, any substance can be, you can add contingency management to any of these programs. We see more success with opioids and stimulants when it comes to contingency management. And the reason for that is because the reward part of your brain is kind of hijacked by opioids and stimulants. So when you provide kind of a replacement therapy through a reward system, they're getting that same release of serotonins or endorphins that they might get when they're using opioids or stimulants. So You're just training their brain to understand that they can be rewarded for other things besides these substances of choice. So some of the contingency management programs, basically, and again, when I talk about these programs, if you decide to implement a contingency managed program into your client's recovery program, it's really designed by you. There isn't a standard kind of design of contingency management, right? So you build it around the client and your resources and your program itself. The way they work, basically, if they're some of the criteria for the contingency management include passing urine or breathalyzer screens, engaging in their personal or family counseling, following medication-assisted regimen, participating in group therapy. They might participate in exercise and wellness programs, just achieving specific goals that are built into the program for the client themselves, or just demonstrating responsibility, including basically building skills, maybe relational or working on, educational goals or job or employment goals. The goals of contingency management, there's actually a lot of goals. Obviously, one is to maintain recovery, including helping patients to form a positive connection between recovery and rewards. When you're not in an active addiction, obviously we understand why it's important not to use substances and not to be, addicted. But when your brain is hijacked by a substance, you're not thinking in that same perspective. So training your brain to understand that, being in recovery can be rewarding beyond, again, just the recovery itself. We know that, that's the greatest reward, but providing them with incentives helps them reach that kind of, that mentality of rewards. And also, a lot of people just like tangible reward systems. I think we all do. We know that probably people who are in rehab, they ended up there because of probably some kind of consequences of either they were arrested or, again, they were court ordered because the judge is like, you can either go to jail or go to treatment. With contingency management patients, they're encouraged to reframe their ideas of sobriety into something that could maybe benefit them personally, instead of just keeping them out of trouble, right? So again, always the larger perspective, staying sober, staying out of trouble, but also associating, again, good behavior with rewards, right? And I think looking at the larger perspective, we know that if a person gets sober, or they have better chance of obviously getting gainful employment, building relationships with people they might have lost connection with. And those are all rewards that are tangible, even if they're not, something that they can hold or spend or anything like that. But it kind of trains the brain to think, to associate those things with reward system as well for doing something obviously positive. A lot of times, when people go into recovery, especially if it's not of their own fruition, it's challenging to get them to stay in recovery. And, there's a large percentage, obviously all the people on this call probably have, understand this, that a large percentage of the people who go into recovery, they don't complete the rehab center program. Using contingency management is an additional way to retain the clients and to motivate them to stay in the program. And again, I say that, again, just providing this additional resource and component of recovery for your clients, it's just another way for them to connect with recovery. We know that, 12-step programs don't work for everyone, or maybe medically assisted treatment doesn't work for everyone, or therapy, or whatever it might be. This is just another opportunity. This might be the connection that somebody who isn't connecting with those other programs is going to connect with, and they're going to really, it's going to resonate with them and allow them to stay in recovery and really incentivize them to do that as well. That's just kind of the down and dirty of contingency management and kind of why the science behind it, I guess, and why it kind of works. The types of contingency management reward programs, there's three types, and they are all associated with kind of being rewarded with the prize system. Again, prize incentives, patients have a clean UA or breathalyzer screen, so they might get to, for the week, they might get to pick from a fishbowl of prizes. There might be, 100 pieces of paper in there, and they pick one, and it's, it can be really anything. And I always say it could be anything from an affirmation, right? Telling them that they're doing great work and to keep it up, or could be a toothbrush or anything really, to gift certificates, any, movie passes, anything you want to put in there, or that you have an opportunity to add to that, you can put in there. They go to a counseling or their weekly therapy session. They might get to pick another prize from the fishbowl. The next week, they're still on track with the program. Again, another clean screen. They get to pick 2 prizes, and then kind of so on and so forth. Again, these are just examples. You design the program however you want to design it, and you put whatever in this kind of fishbowl prize incentive program that you have the opportunity to do so. Again, it's based on the resources that you have available within your organization. So the second one is a voucher-based incentive program, and this one kind of just builds on the value of the incentive each week that the individual stays on track with the program that they're in. So the first week, again, they maybe they complete all of the criteria in their program, so they receive a voucher that week for $5, and it's to either a grocery store, a gas station, or whatever it might be, right? The next week, they maintain the program. They complete all of the steps in their program, kind of according to the program itself, and then they get a $10 voucher. So it kind of just builds the value on top of the vouchers, makes them more obviously enticing for the individual to stay on track with their program. If for some reason they don't stay on track with the program, again, you can design this however you want. They might just not get a voucher for that week because they didn't complete the program, or they might have to start over, right? So then this week they go back to, when they get a clean UA or whatever, or complete the program requirements, they go back to getting a $5 voucher. Again, you can design it however you want. They might stay at $10, and then on the 4th week, they get a $15 voucher. Again, these are just example numbers. Whatever your numbers are your numbers. That being said, just to a little bit of information. So again, when you do these contingency management or motivational incentive programs, you probably want to budget about $600 per client per year for the program itself. So they're not inexpensive, and obviously, these programs can be built around donations or, anything, community donations. You might, visit, some store that wants to donate, again, toothbrushes to your program, or socks, or whatever, right? So you can put these on the list of things that they can win in these prizes. So it isn't always financial. It isn't 600 like actual dollars. It's just obviously these are numbers of the value of what this program might be. The last one is direct rewards. Basically, some rehab centers that utilize contingency management therapy, they provide direct prizes instead of using the voucher method. Again, those things can be, if they complete their program, they might just get a standard $25 gift certificate every time they do. But that's kind of just the direct rewards program, and it's pretty straightforward and simple. No kind of real design elements to that. You just decide every week if they complete it, they get X, Y, Z, and hopefully that's enough to keep them kind of motivated to keep moving forward. So that is kind of the gist of kind of contingency management. Again, I'm a huge advocate of adding this as a resource for all of your clients. I know that it's easy for me to say that because I don't have to implement it, but the kind of science and the proof behind the effectiveness of programs like this, especially with individuals who are using opioids or stimulants because of the way the brain works and the way it affects those types of things, those types of substance use disorders. This is a great tool to have for those individuals. Again, I think it's a great incentive for anyone in recovery. Again, and I tell people, it just really, when these people come in, it just really needs to be designed as part of their program of recovery. It's not going to be effective and work for every single client. Obviously, nothing does, but it is going to work for some of your clients. And I think that's the most important part of kind of contingency management itself. So I'm going to stop there. And if anybody has any questions, certainly feel free to ask them, and I will try to answer them.
Awesome. Thanks, Norman. James has his hand up.
Yeah. Norman, thanks so much for that presentation. The one question that I had, and I know you said you could really build these and tailor them to what works best for a program, but the frequency at which an incentive is earned, I mean, is if somebody's involved in a day treatment program that's 5 days a week, is 5 days a week too much to get a small incentive, or is monthly too infrequently? So I guess my question is there any parameters on the frequency for earning the incentives?
Again, I think these programs are designed around the resources that you have available to you in your program. Most of the programs that I've seen implemented are designed around kind of a weekly incentive. I don't think I've ever heard of one that provides like daily incentives. I think that could get super costly for you if you're providing people with a daily incentive. But for the most part, when they are designed, I think that most organizations or programs are designing them with weekly incentives, especially because if you're doing the fishbowl or the voucher-based reinforcement, a lot of times those numbers are increasing. So if you're picking from the fishbowl, you might get one pick one week. The next week you go to two, right? So that means they have an opportunity to win two prizes with a specific cash value. So if you're kind of getting into a daily situation, I think it probably can get pretty costly depending on the number of clients you're serving. And of course, these are programs that are, at this time, they're not funded by insurance companies. I think maybe there are some pilot projects that are going on where insurance companies are looking at contingency management and funding it, but no other organizations are funding it except for the VA. The VA does do a contingency management program right now. And so, once that has kind of been in operation for a while, I think we'll get some better kind of numbers in terms of the effectiveness of contingency management itself. But right now, insurance companies won't fund it. And if you're using dollars like Medicaid, they allow you to spend up to $75 on this program itself. Now, a lot of people are like, that's a cap from Medicaid, but it isn't a cap. Basically, all they're saying is that $75 of their dollars can be used. Obviously, if you have additional dollars that are coming from other areas that you build in or that are it's allowable spending, then you can provide those dollars to participate in this program itself.
And I did, just to piggyback off of that, Norm, so with our state's SOAR funding, I did put in the chat what we have as allowable expenses for this. And so that is the highest any one contingency could be is $15. And then we do have a cap of $75 per person per year, which unfortunately doesn't sound very close to the 600 that you recommended to budget for. So, and I would assume that my next question is it better to do 75 as a cap than nothing? And I would assume you'd say that's better than nothing. Would you agree, Norm?
Yeah, and I would say that, and I don't know what your program's thoughts are on prize incentives, right? Is this a $75 value, like 75 like cash value, cash dollars, right? Whereas, when I say $600, it could be, a $10 clock radio, right? That you got donated to your organization. So, it might be 75, then that's 85, right? And so these prizes have value too. And if they're being donated to your organization, you know what I'm saying, to be, you can build them into that figure itself. So it is an actual dollars, you know what I'm saying, that are being spended. You kind of build it however you want. That's a great
point. So I'm glad you expanded on that because so I just want to say this, kind of repeating what you said, that if an organization has donated toothbrushes or donated small cash value clock radio, things like that, those could go towards the $75 that we have, and then basically make it so there's more that can be offered. Okay, great, thank you.
I have a question. Since you're aware that this has been going on for a while, have you done like follow-up with people that have successfully completed the programs? And have they given you ideas of how impactful this was in their recovery, or what they found to be the most valuable part of this in their recovery? Do you have any, data on that?
So I will say this. So we a lot of us within ORN were trained in contingency management, and it was because they wanted us to go out and provide information about the program itself, so that programs could build it into their recovery for their clients. And so we have mostly been going out and doing these presentations for individuals. I haven't actually assisted anyone in implementing a program yet. I think the biggest roadblock for them is the dollar figure, right, and the money, and where to get these dollars to implement this portion of the program, in addition to the resources, right? Because I can say, I mean, it sounds simple when I just talk about it, but somebody has to manage this program, right? And it's probably going to be more than one person, right? Somebody's going to have to manage the financial aspect, whether people are staying on track with this program, where these prizes are coming from, where this money is coming from. So, there are a lot of other things to consider when implementing it, not to detract from the benefit of contingency management. But it is fairly new. I think, the $75 Medicaid, Medicare thing is a little confusing for organizations. So again, we're not seeing a lot of people who again, the VA is doing it. There are a few pilot programs, but I haven't directly worked with any organizations to implement a program yet. So I don't think I have the answer to your question at this time.
Thank you.
Karen, I'd like to just add a little bit to that. Contingency management has been around for decades. This is not really a new approach, but ORN is new to it because we have stepped into providing services for stimulant use disorder as well as opioid use disorder. And that is really where contingency management has been utilized for these decades, is really specifically for long-term kind of support and recovery support to people who are primarily methamphetamine and cocaine dependent. So the statistics, the backup, the evidence-based evidence-based practice about contingency management has come from those decades of utilizing this approach, one approach for long-term support in patients who need long-term support for recovery. And because of the healing that needs to take place in the brain and the engagement that's necessary to get people involved and staying involved in just coming to services. So that's really how contingency management was developed, was to really begin the engagement process, to, as Norma said, to reset the brain, to look at how these positive things can happen in a life of recovery, and that to introduce people to feeling really good, and not just the clients, not just the patients, but the people who are providing services in a long-term basis to people who have such high relapse potential with stimulants and with opioids now too, that you want to keep people engaged and involved and supported if there are lapses into continued use, because that's the expectation for many of our clients, is that there are going to be those episodes, and how do you support them through that, and how do you keep them engaged, and so this is one effort on the part of a staff who also looks at dealing with these issues in a more positive way. That's the one thing that I really like about contingency management, is it not only incentivizes those clients, it incentivizes the staff who see these positive changes. You know, in the start of contingency management in programs with patients who use multiple substances, is the focus really with contingency management was on directly addressing the stimulant use first, and then having an opportunity when the brain is healing to address other substances as well, alcohol, marijuana, you know, what other kinds of substances of abuse, but this is the beginning, this is the healing part. So that's what there is significant amount of information about contingency management being successful in an evidence-based practice for, as I said, a long period of time, but we're new to it. We're learning from it too, and the ATTC is really providing a concerted effort, and so is ORN, on really developing a lot of expertise with people who've had great experience with this in the past and are developing expertise with it now. So hopefully that'll answer some of the questions about you know, where this came from and why we're advocating so strongly for it.
And I'd just like to say, you know, kind of the way we think about it, you know, kind of talking about how the incentive portion of it is like opioids and stimulants have hijacked that rewards part of your brain, right? And so now that's the only reward your brain kind of responds to when you have that addiction to it. So, you know, I always think of it like we're trying to hijack the brain back, you know, to let them know that positive behavior can also give you that same feeling, right? The you know, doing positive things and in recovery can also give you that kind of serotonin release or that endorphin or that euphoric feeling that you're getting from opioids or stimulants. So, you know, again, like I said, I like to say we're trying to hijack the brain back to kind of back to where it all started, right? So getting an allowance for making our bed every morning, you know. So, but yeah, anyway.
Are there any other questions?
Hi, this is Robin from Central Valley in Jamestown. And I just wanted to add, I see there's a lot of public health folks on the call today, and incentives are well-documented prevention methods that are used as public health practice in a lot of different things. We've seen it with COVID. Colleges were providing incentives for kids to go get tested. We use incentives for breast and cervical cancer promotion, and if you're screened, you get an incentive. So actually, some of us in public health have financial resources through working with incentives and other programs. So I think this is a great way to bring it into another dimension or another program or another aspect. And I think there's some of us out there that might have the financial means to provide some of those incentives in our communities. So I would be happy to work with someone in my community because I have some money that I've raised through some various things. So just throwing that out there.
I'll just want to point out in the chat that there's 2 research articles that were posted. So the first one, it identifies some of that effectiveness of contingency management. The second one actually has a implementation form at the end, and so that might even assist with some of those nuts and bolts. How do we get this into action? Types of steps, and I think it's more of a guide than you need to follow every single question on here. Or that's how I interpret it. But Robin, I mean, if there's any way that we can assist you in getting something like that going, let us know. And maybe the first step is finding a partner, a program that would want to implement it locally for you.
Yeah, most definitely.
And if you need we did do the presentation for another program here in Fargo, and they're looking for resources in order to or somebody to partner with to implement a program like this. So and they're fairly new here in this area. So I mean, if that's an option for them, that's great. We can certainly I can put you in touch with those individuals as well.
Sure, and I think might not be something that we'd sustain for a long period of time, but there would certainly be, we certainly have some funds that are available that have been given to help women with various services and screening tools. And so I think if we did that as a partnership and that incentive was used and then it resulted in some service that was a public health related, I think that would even be great because then we're reaching people for multiple things. Whether it's vaccinations or, breast and cervical cancer screening services or other things. So lots of ways to partnership. We just don't have enough hours in the day to work on everything, right?
And I'm an eternal optimist. So I'm like, so I look at insurance companies and see that they, do these gym membership discounts, right? So you go to the gym X number of times and they're going to pay part of your gym membership, right? So my hope would be that they would see the value in something like this and really want to, latch onto it and provide it as an additional part of the program, to pay for individuals in recovery. I think especially, with the statistics of the success rate with individuals who are, using opioids or stimulants, I would hope that the insurance companies would see the value in that. Am I confident that that's going to happen? No, but I sure hope it will.
Well, they certainly are moving more for that. If you have Sanford Health Insurance Plan, we could all get $250 if we just went online and filled out the information. We could get that incentive ourselves.
Are there other questions for Norman? All right. Well, seeing none, I appreciate it, Norman. That was really good information you provided. So I'm glad we're recording this. We'll definitely have this posted for the other grantees who weren't able to make it. Katie's informed us that they are in a blizzard on the eastern side of the state still, and that they were closed down this morning. So that might be hindering our participation a little bit, but.
And I think, could we share your contact information, Norm, when we send out our email to folks following up on this meeting? Would you be good with that?
Yeah, absolutely. And just kind of before we part, if you are interested in any organizations interested in adding contingency management to their program, you can always reach out to the Opioid Response Network and submit a request to us. And, we have consultants that are able to assist you in designing and developing a program around your organization and your needs and your client needs. So feel free to submit a request again to the opioidresponsenetwork.org. Right, Marvin? opioidresponsenetwork.org. And then it'll just say submit a TA request. And, you know, if you're interested in doing that, you can certainly do that there. But yeah, definitely share my information. If anybody has any questions for me, I will, you know, be glad to answer them.
Awesome. Thank you. And I saw that it's in the chat. So that Opioid Response Network, how to submit a request is in the chat. So make sure you copy that down. Awesome. Thanks. Okay, so I guess next on the agenda is the state updates and then grantee, maybe some just brief updates, but we'll go with state updates. I think James just has one, just something simple to share, I believe. So I'll turn it over to James.
Great. Yeah, and so the only state update that I had, and we can give you guys an opportunity if you have any questions for us, but there was a bill that was passed with an appropriation during the legislative session to expand our substance use disorder voucher system to include 2 grants to create new programs in the state. And then during the special legislative session that convened in, gosh, was that November? There were 2 additional awards that were added to that funding source. So I just wanted to let everyone know that the Department of Human Services will be issuing an RFP this week for up to 4 awards for new substance use disorder voucher programs in the state. And then to align to the legislative intent, those will be programs that have to have less than 17 beds for substance use disorder treatment. And so, like I said, that will be coming out this week. And then programs will be eligible to apply for those in underserved areas of the state. So just wanted to give you a heads up, and hopefully, you know, we don't know what kind of proposals we will receive, but hopefully there will be some connection to OUD treatment and expansion to MAT services in the state. And if nothing else, there should be some programs applying to at least expand SUD programming throughout the state. So that was the only update that I had that I wanted to make sure I gave to all of you in this meeting today.
So any questions for James? All right, so we have a little bit of time left. I don't know if any of the if anybody has anything that they want to share, like maybe a major update or a success story or something like that. If you want to take this next 10 minutes, we could just do that if you wanted, or if you have questions about the grant or implementation, anything like that, we'll just kind of open the floor. So if somebody has something, go ahead and just speak up. I know a lot of you reach out with questions and stuff like that in email, so a lot of your questions are probably answered, but.
This is Karen. I think I sent an email to you all, and if you responded, I apologize because it's probably lost in the mass of emails. But I had a question because, you know, I'm working on the MOU with the jail and the correction center here in our region. And one of the questions that they had for me was, can the grant help pay for medications for MAT for those patients or clients or, you know, whatever that are being discharged from the jail and don't have the resource and don't have the Medicaid yet or that kind of thing. And so just kind of wondering if that's a possibility.
Yes.
And how long can we do that for?
Yes. So sorry to interrupt you, Karen.
Okay.
Quick answer is yes. That is entirely what the funding is intended for. And how long? I mean, there's not a set duration,
Okay.
but it would be, I guess, until there is another funding stream that's available. So, for example, if somebody is applying for Medicaid, you know, they could use the funding until they get notification of approval. So we don't have a guideline saying there's a maximum amount of time that somebody could use this funding to pay for their medication.
Okay, and then, and I don't know if this is still a thing, but I remember when we had, some training in Bismarck, this has been a while ago, about, how sometimes Medicaid and their guidelines for approving payment for MAT, if they missed, some doses, then they kind of were taken off approval for it. And then they had to, again, show that they were going to be compliant, if you will, that kind of thing. So are those hurdles still in there? And so in a case like, let's say if somebody, got into maybe the outpatient program that the jail is putting together now, but they're not eligible to get that because they kind of fell off, if you will, and now they want to go back and get back started in it. But do you know what I'm asking?
Yes. So I can't speak to the barriers. And so I would rely on, the rest of our colleagues on this call to speak up if they know otherwise. Because, when I hear from Medicaid, it's things are going great. And I know that's not always the case. So um, I can't directly answer what those barriers may or may not be. But I would say, so if there are instances where Medicaid is a payer source and then Medicaid is no longer a viable payment source, then this funding could be utilized. So the whole intent is it can't supplant another funding source. But I would say in the instance of Medicaid is a funder, and then for some reason they're not a funder, whether that's due to compliance issues or not, I don't think that really matters as far as utilizing the SOR funding.
Okay, great. Thank you.
There was a question in the chat from Bev. Could contingency funds be used as an incentive for a client to seek treatment services such as Face It Together, peer support, etc.?
Yes.
Okay. Yeah.
Yes. So the way that the SOR funding is utilized, it could be prevention, early intervention, treatment, or recovery. So when if somebody is potentially using it for a recovery support, then I would, I guess I should defer to Norm on if it's best practice or if it's allowable, I guess, to utilize for recovery support. But as far as funding, there's no reason we couldn't have it utilized for a recovery support.
I guess I'm not understanding the question. What?
Yeah, Bev, do you want to maybe?
Yeah.
Can you unmute yourself and maybe just ask again?
Sure. I'm just thinking, there might be people out in these small rural communities that don't want to go in or don't even acknowledge that they may have an issue. But by incentivizing them with either monetary or some kind of gift to get them to seek out treatment or be evaluated, I was thinking maybe that would be one way to get them in the doors, so to say.
Okay, so I need to backtrack on what I just said. I apologize. So I need to draw a distinction here. The funding that's available for an allowable activity is to reward and incentivize treatment compliance. So when I said recovery, that was incorrect. So it has to be for treatment compliance.
So then to answer Bev's question, probably it would not be allowed with SOR funding to try to incentivize somebody to seek treatment.
Well, it could be to seek treatment, but not for a recovery support service.
Gotcha. Okay. All right. So other questions?
This is Holly. I had a Narcan question. So Katie had just sent me the link to the training, and we are working on updating our information based on the new storage, information that somebody, I can't remember who sent it out, but so it was pointed out to me that that link is not up to date anymore, like, because the storage information has changed. And I think the manufacturer has a new link. So, we might want to be getting that out. But my question was, so we make the little labels, to put on the boxes of Narcan. Is there a format already available so we don't have to recreate the wheel? Because, we have the website on there where they can watch the training video. And then I think we also label it like, if you use this, email me. And so I'm wondering if there's a template already available for a link to training, but that we need to update the training video too. Do you understand my question? I feel like I'm talking in circles.
I believe so. So you're saying that you just want an updated link?
Well, I think we should the link we put on there, I think should be the updated version of it, so it's accurate. And then I'm wondering if we could get, like, if you guys have labels, I know you didn't used to label them, because the link that we have now isn't accurate. It's a dead link. It's like stop overdose, that old link, and there's no, it's inactive anymore. So I just need a new active, accurate link that I can stick on my Narcan so that people can have access to accurate training.
Perfect.
Yeah,
yes, we can do that.
Yeah, we have to, because we do the stickers when we're the ones distributing. So I would imagine we have to have a template.
Okay. So yeah, if I could get that, that would be great, so that we can get that accurate and current. So thank you.
We'll make a note of that now, and once we get that, we'll get that out to everybody.
Perfect. Thanks.
And thank you for letting us know about that.
Sure, I didn't catch it, but one of my staff did.
I just have one other question that's really kind of maybe not necessarily related to all of this, but I remember when we did have that training that I was talking about. I know, James, you were there. We had it in Bismarck probably a couple of years ago. And we had someone, I think, from the Attorney General's office speak. And I am thinking his name was Aaron, but I could be wrong. What's his last name? That's Aaron, what I thought it was. Okay, perfect. Thank you. We're thinking of trying.
He does a great job of presenting and giving information on the laws and stuff like that. So
yes. So thank you.
Yep. All right. Other questions? Anybody have any success stories that they want to share or anything like that? All right. Well, we're going to end about 8 minutes early, so this is kind of good. Good for a Wednesday. Get 8 minutes of your life back. Katie gets to dig herself out of her blizzard.
Last quick question. So I missed the first part of the call. So you guys will send out a link to the meeting, is that correct? Or the first part?
Yep, to the recording. Okay. Yep, we sure will.
Okay,
yep.
And please know if any of you guys have any topics that you'd like us to cover in the meeting, or if we can get presenters like Norm in, please let us know, because I'm sure if you're thinking it, everyone else is as well. So definitely shoot us an email if you have any ideas of trainings you'd like us to bring up in the next year.
Absolutely, or trainers or anything. Yeah, we could do this monthly. We could do this quarterly. We're open to suggestion, guys. And we are still working
every
on
day.
Yeah, well, I don't know about that. But no, we are working on a training and technical assistance proposal, and we are going to have some very good trainings, in the upcoming year. So just be aware of that.
Tom, this is Oliver from the ONE program, the Opioid and Naloxone Education Program at NDSU. I just had a few really quick updates, and I won't take up too much time. We've had the follow-up, the pharmacy technician, pharmacy student, pharmacist doing follow-up calls after the dispensing of an opioid. We have over 13 locations now participating in that. So we've had a lot of really great uptake, focusing on, of course, proper use, but in addition, more so proper disposal of the opioid after they're at home. We have over 900 screenings from the home health, hospice, and public health home visits across the state. And we're optimistic, and we have 2 large health systems in Fargo that are looking to also participate with their home visits with their institutions. So in the coming months, we hope to have additional good news about that. And lastly, we have 3 of our team members are going to be calling pharmacies and local public health units in the next month or 2. And we have had a lot of pharmacies across the state reaching out to me about the extravagant copays or cost of naloxone or Narcan for their patients. So with many prescribers now co-prescribing Narcan to go with that opioid after a surgery or after an acute injury. When they're at the pharmacy, after billing Narcan through the insurance, the costs are running anywhere from $100 to $200, which of course is off-putting to the patient, as you can imagine. And we're seeing them then refuse the Narcan prescription due to the cost, but then take home the opioid. So our goal is that we are contacting pharmacies and local public health units, hoping to make kind of revisit that link between those 2. And if there is Narcan at the local public health unit, that they would be willing to share with the pharmacy or arrange some sort of partnership to improve accessibility for those patients in any way, shape, or form. That will be our goal. So you'll be hearing from the local public health units, will be hearing, and we'll be pestering you from the one program in the coming months for that kind of outreach opportunity.
And Oliver, this is James with Department of Human Services, and it sounds like maybe there's a very easy solution to this that we're missing, because we are able to, we order in such bulk quantities Narcan at the state that our rates are nowhere near what you just indicated self-pay is.
Right.
And we can easily provide the Narcan to public health units to get to those local pharmacies so that they can distribute to patients at no cost. So I think maybe we're potentially missing an area of collaboration here.
Yeah, absolutely. And with that being said, James, I know there are a few public health units that have been very proactive in supplying pharmacies. So I didn't want to make it sound like that this isn't happening, because I do know that the public health units and pharmacies there's some really extraordinary partnerships between those 2 going on right now. But like you mentioned, there are a few that either the pharmacy didn't know about it, or maybe the local public health unit talked to the pharmacy and then they kind of forgot about it, that was an option, and then, kind of out of sight, out of mind. So we're just hoping to kind of improve that linkage. So yeah, and that's great. It's really good to hear that there is that supply there, and that's not going to be a barrier to the pharmacy or the local public health unit. So that's good news.
So in Bismarck, I reached out to UND Family Practice Pharmacy, and I'm providing them opioid education kits, we call them, and they get Narcan with the Deterra bag. But it would be helpful, Oliver, if at the public health unit, if we could get the pharmacies that are interested to partner on this. If you guys are making the phone calls, that would just help us reach out to them to provide it to.
Absolutely. So, and that's something that this is kind of still in the works is, who do we call first? Do we call the local public health unit or do we call the pharmacy? And with that information, maybe it's best for us to call the pharmacies and get that list of adopters to the program, and then follow up with the public health units. Is that kind of what you thought would work out best?
It would for us here at Bismarck Early Public Health. Yeah.
Okay. Thanks for that information. That's super.
Yeah, this is Holly at First District. Yeah, we also provide Narcan to pharmacies. Just we haven't been good lately about contacting them, but if they inquire, we always give it out. But Sue, if you could send out like a checklist of what you put in that kit, because I think that's a cool idea.
Sure, I'll send that. And then I made a label. I just used brown paper lunch bags and put a label on it. And then the pharmacy took 10 of them. And then I reach out every month to ask if they need them replaced.
I like that idea.
And I do have to say one more thing. It's really great to hear that proactive communication with the pharmacy and supplying the pharmacy with that Narcan to the units that are doing it. It's really, really awesome. And when you think about $150 for that patient to expect to pay for that medication down to $0 because it's covered by the state, is just a huge hurdle that we jump over, and making sure that we have the right medication in that high risk, those high risk patients. So thank you very much for all your efforts. We appreciate that.
Here in Dickinson, I have to say that it has improved. When I first went out to the pharmacies to talk to them about creating an MOU to, do whatever, we could either replace the Narcan for them if they gave it out, and it cost them, or we could do the copay, however. And so we've done it both ways, depending on the pharmacy. But initially there were some pharmacies that really didn't want to get on board with it. But I have to say now they are. And I think I've just got one pharmacy in Dickinson that I don't have under an MOU yet, but that's my next goal, is to get them on board.
It's awesome.
Do we need to have MOUs if we're doing this with the pharmacies?
I don't see there be a requirement for it. No. Anybody else? I think it's whatever works best for you.
Yeah, I would say as long as your agency's okay with it.
Yeah, and Michael said that he doesn't have an MOU either. So. Yep. All right, well, good. Okay, well, it's a little bit past 11. That's kind of what we had scheduled, is up to 11. So yeah, great meeting, guys. Again, I appreciate Norm coming on and giving us some information. I always love learning about that kind of stuff. So, all right, and then we'll send out the link to this video and everything else. So we'll get some other